Hi, everybody. My name is Hani Hattar, and I come from Sweden. I work mostly with pain management in Ehlers-Danlos syndrome and HSD. But today I will talk about something else which is very much important, and it's culture and pain. And why do we talk about culture and pain when we are talking about pharmacology and we talk about molecules? And well, because we are human beings, and we are going to talk about how do I feel as a human being when I come from different culture, meeting, for example, caregivers who don't understand me, or vice versa, when the caregiver comes from other culture and we don't understand the caregiver. We'll talk about culture and pain. And to start with, we will look to some definitions about culture. There are like 60 to 70 definitions about culture, but I have picked 3 of them. And as you see here, it's highlighted that we talk about what we believe in, what we have been taught to thought, how we are taught to communicate with each other. And it's a kind of lens which we use to see the world through. And this lens is the culture which we have been grown up in. Well, as you all know that in the world, we divide the cultures in me or I culture and we or the group culture. As an example, if we talk about me culture or I culture, it's, for example, Scandinavia. I come from Sweden, and it's totally very much based on the individual, himself or herself. But when you talk about, for example, the we culture, we take an example, for example, the Middle East, where we talk about the we culture. The group culture as well, we can talk about in the Far East, for example. And what is the difference between these two? Well, I still emphasize that we talk about we are human beings. The difference is not about us, the human beings. The difference is it is in the behavior. The difference is about how we translate what is going on around us. So in the me culture or I culture, it's the guilt culture, because it's based on the person herself, and it means that what you do, what you achieve, it is your own. So always I have to emphasize to be individualized. I have to decide what will I do with my life. On the other side, in the me and we culture, I can decide over my life. As an example, I was born in Jordan, in the Middle East, and I wanted to be a pilot. But of course, my mother, who was a nurse, she wanted me to be a doctor. And you can see the result. I'm a doctor. I'm not a pilot. But when I went to Sweden I met my wife, who's Swedish, she thought that, of course, you should be a pilot. So I'm a pilot as well, because of her. So thank you. So this is how you see how it is me culture and we culture, how in the we culture, the group decides upon you, and they tell you what to do. And in the I culture, it's me who decide. That's why I try to put these, the exclusion and the inclusion, that in the me culture, so as to be individualized, you have to exclude yourself from the others, how they think, because I want to think by myself. I have to decide myself. Whilst in the me culture, you have to be included in the group and in the group's way of thinking, so as to be accepted. So it's interesting to see how it's in a way different, even if we are human beings. And this is just a map to see roughly how it might be the me and the we culture roughly in the world. You see the green color. It's mostly the achievement culture, because what you achieve is yourself. Whilst in the red one and the yellow one, it's the group culture and group and relation culture, and it is how you relate to others is what you are. And now I start to talk about more seriously about body and culture. As you know that body structures, as we have heard, the physiology, the anatomy, everything is the same. No matter if you are from South Africa or from the North Pole, it's the same. The liver is on the right side, I hope, and the heart is on the left side. So the physiology and the anatomy is the same. So this is very much important. That's why Sir William Osler said, understanding the patient who has the disease is more important than understanding the disease the patient has. And this is very important. We don't just deal with the liver and the heart and the joints and the collagen. We deal with the persons who have the liver and the heart and the collagen. So that's why we have to understand the individual, the person who has the problem, so as to deal with the problem. Okay. Now, why should we talk about culture when we are talking about EDS and HSD? Well, as we understand that the major problem in EDS and HSD, it's pain and fatigue. And when we talk about pain and fatigue, we talk as well about brain fog, and we talk about stress, we talk about depression, we talk about sleep disturbances. All these parameters, they are, as I call, soft data. We can't measure them. I can't send you to an MRI and then get for a result that you have pain. Even if I work with pain, I don't know that you have pain. It's you who's telling me that you are in pain, the chronic one, of course. Because if you have a fracture, it's easy for me to understand that you have pain, you have a fracture. I have operated you, I know that you have pain, post-operative pain. But the problem that when you have chronic pain, so it's you who tells me, and it's soft data. And we will further, we will see how this soft data has an impact on the translation of EDS, HSD symptoms in the culture-wise. To understand pain, now my colleagues have talked about pain, and I told my colleagues, why should I go up and talk? You have said everything. So anyhow, when we talk about pain, when you get pain, you have to be, first of all, you have to know that you have pain. You must be aware about pain, and you have to communicate about the pain. And what we talk about, the communication is very important, because this is the key about talking about culture and pain. The communication is very important because, as I told you, if you come to me, I can't see that you are in pain. You tell me that you are in pain, and then I start, in a way, to translate your symptoms. And it depends about what you tell me. And the communication is verbal and it's non-verbal. The verbal, you say, ouch, I'm in pain, it hurts. But the non-verbal, I could see that you are in pain. Maybe you can show me with your body language that you are not feeling well. You are not feeling at ease. So this is how we communicate. And this communication is very much important. So through the decades, we have, in a way, developed a very sophisticated ways of communication between us, the human beings. And these ways of communications, they become culturally dependent. So in different cultures, we contact each other differently. So that's why, for example, if I meet a person who is Scandinavian in Jordan, I wouldn't understand exactly how they feel, because we will see how we behave when we have our pain. So communication is very much important, and that's why there are those four key components which we have to think about when we have this transcultural meeting. Well, we always talk about disease, illness, and suffering, because pain, when we talked about pain, and if you read the Bible, for example, pain is suffering. So suffering is always used to show that there is that pain that is, in a way, could be a punishment if you are not behaving well. So in some cultures, it is believed that the disease, the suffering, it could have natural or supernatural causes. And what we will talk about now is the impact of natural and supernatural causes that make the patient and the caregiver translate the pain and try to deal with it. So when we look at the culture and its influence, there are beliefs and perceptions how we have to communicate our pain to others. So if you look, for example, in the Middle East, if you are in pain, then you have to show it. But if, for example, in some countries like in the Far East, if you are in pain, you don't show it. But both of them, they are in pain. There was a very interesting study that was done. They looked at patients or persons. They were healthy persons from Belgium and from Japan. And it was a very, very simple study. With a needle, they stuck it in the gum, and it's painful. You know how it feels when you go to the dentist. So they stuck a needle in the gum. And then there was a person who was observing the patient who was stuck, and there was another one who asked, how much pain do you have on a scale from 0 to 10 or 0 to 100? And when they looked at the data from this study, they saw that people who came from Belgium, they said that it was too much painful, so they said it's like 8 or 9 or 10 on this visual and analog scale. It's called VAS. So they had very much pain, but they did not show it physically. On the other hand, people from Japan, physically they could show that they were not comfortable. But when they were asked, how much pain do you have on this scale? They had like 1 or 2. It was the same procedure and in a way the same pain, but it was how I express my pain. And then it is up to me, who is the caregiver, how I translate this expression. So it's very much important to always think about how to deal with persons who come from different cultures. And that's why, for example, the pain expression in different cultures, as we all know, it's divided in stoic or emotional. And the stoic one, the stoicism, for example, it's very well known, like in Scandinavia and parts of Europe and in Japan, as we talked about. And when you have this stoic behavior, then you don't express your pain openly. And you have always very high self-control. And you don't put, in a way, too much pressure on the caregivers to treat you. That's why, for example, in some hospitals, they don't give painkillers after acute surgery on demand to persons, for example, from the Far East, because they know that they are stoic. They will not ask for painkillers, because when the nurse comes and asks you, are you in pain? No. The answer is no, but they are in pain. So that's why they get the pain medication the very first week post-surgical. They get it regularly because they know they are in pain, but they don't tell. On the other side, if you look at the emotive, for example, as I told you, like in the Middle East, well, you don't have to say that you are in pain because you show it. You show it physically and verbally, and not only you, it's your group who shows it. That's why, for example, when persons come to the emergency room, usually, and we look in Scandinavia, it's the person come by himself. But if you look, for example, in the Middle East, then there are like 2 or 3 or 4 or 5. And usually they ask, where is the consultant? They don't want to have a regular doctor. They want to have a consultant, because the group are interactively dealing with the person, with the patient's pain, showing that the person in a sympathetic way, that the person is suffering. And this is a big difference between when you are emotive or when you are stoic. And that's why the cultural barriers that could be created between the caregiver and the patient could, in some instances, they could give us, or the patient, from problem in getting a very well-designed treatment or rehabilitation. So, as you see, it's the communication, how you communicate, and how I understand the communication. Young talked about that there is the majority and the minority cultural meeting, which means that no matter if you come from different culture or the same culture, if you are a minority, for example, a pain patient is a minority coming to me as a doctor because I decide, which means that the minority accepts sometimes that the majority could dictate what is right and wrong, which means that I, as a caregiver, I could tell the patient, this is your problem, this is what you should do. Whilst if there is acceptance that there is no majority and minority, but we are human beings, and I have a profession, I am a pain specialist, but I understand that you are a person suffering, then I could communicate with you without creating this minor and major. Okay. Now, as I told you, we come back to EDS and talk about why is EDS interesting in the culture and pain. Well, as I told you, there is pain and there is fatigue and sleep disorders and anxiety and depression and so on. And so as to clear this one, as you see, in different cultures, when there is soft data, when I can't get the results by making, for example, MRI or taking a blood sample, then maybe it could be translated that it could be the evil eye that caused your suffering. Mal ojo, for example, we say it in South America, or it could be jinn, or it could be demons, or it could be susto. Susto, it's used to describe, for example, post-traumatic stress disorder. Butbada or Karani, that is used, for example, in India or Pakistan, parts of Pakistan. It could be that my ancestors are not happy with me, that I got the pain, the sleep disorders, the fatigue, the bleedings, the problems with my libido, and so on. So we start in different cultural way to translate this soft data by using this supernatural causes. So, and this makes the patient and the caregiver, if they come from the same culture, they agree how to deal with the problem. So, especially if you look at the last one, body structure and hypermobility. In the Middle East, I have been talking to persons who were hypermobile. Men were not comfortable to get their diagnosis hypermobility of the joints, because when you are hypermobile, you are feminine, and it's a macho culture. So they don't agree that a person is hypermobile or has loose connections, as we say. That was something which struck me when I was dealing with persons in the Middle East. This, as well, it was told by my colleagues here about the presence of ultra-rapid metabolizers. So as you see, for example, in parts of Africa or Ethiopia, there is like 29% of the persons who we treat with opioids who don't respond to opioids properly, which means that we have to give them higher doses. Whilst, for example, in North Europe, the number is 1 to 2%, which means that in Sweden, for example, we give 4 to 6 milligrams morphine 4 to 6 times a day, and it's enough. But if I have a patient coming, for example, from Ethiopia, and I give them the same dose, they are still in pain if they are ultra-rapid metabolizers. So that's why it's starting now to talk about more and more about Eastern and Western medicine. What is Eastern and Western medicine? Well, the Eastern medicine is the old medicine, which is still used in a lot of parts of the world. It's like a traditional Chinese medicine, it's Ayurveda and Unani Tib, which is used, for example, in the Middle East. And the Western medicine, which is used mostly all over the world, it is the evidence-based medicine, and which is based on psychosomatic approach. But there is as well another practice which is used a lot of parts of the world, which is called the folk medicine. And the folk medicine, you have people who treat the pain or treat the suffering but without being educated like in the Eastern or Western medicine. They are priests or they are healers, and they use voodoo. They use, for example, kai, which is used in the Middle East. It's cauterization, and for example, susto and butbada is treated as well by priests, when we talk about post-traumatic stress disorder. In this picture, I tried to illustrate how it could look like in the Eastern and Western medicine. If you look at the Western medicine, it's mainly based in the body. We look about the problem in the body. That's why we call it open and see. Okay? And then if you don't find a problem in your body, then we start to look if it was psychological. But whilst in the Eastern medicine, we look if it was spiritual, because it could be that your ancestors are mad on you or so on. And then we look in the body. But when you talk about the Western medicine, I can tell a patient in Sweden that, for example, that it could be in your spirituality that you have pain or you are suffering. It's the same, for example, in the Middle East or the Far East, some places. I can tell the patient that the problem is psychological. They will be mad on me. Because if I tell them that it's psychological, then I'm telling them, you are mad. And they don't accept it. So you see that there is a lot of differences in the way of thinking and the way of approaching the same problem, which is pain, fatigue, and distress. Well, if we think, why do people amaze us by seeking traditional medicine? They come to us and we give them the remedies, and still they go to a healer. Why do they do that? Well, in the research, we found out that there are a lot of parameters. Maybe the Western medicine is too expensive. You know that it costs, for example, to do MRI or whatever. And maybe it's the language barriers, as my colleagues said. I have to communicate, as we said. If I can't communicate with my body and my language, then I have a trouble. So that's why maybe it's language barriers that's a problem. And maybe I'm not satisfied with the kind of practice that is used by the Western medicine. If they will tell me, well, this is psychological, thank you, I'm not mad, I will go and talk to a healer. And of course, it is the group as well that decides over me, maybe that tells me, you have to go to a healer, even if I was meeting a doctor coming from the Western medicine school. And so, and it gives me as well to feel at ease, because we talk about placebo and nocebo. Placebo, as we heard, it is the body functions that activate my inside opioids that makes me feel well. But there is as well nocebo, and nocebo, it is as well when I don't feel well, then I activate something which is called cholecystokines. And these cholecystokines, they block my own opioid morphine effect in the body. So that's why if I'm not feeling well, then I'm in the nocebo mood, and the nocebo mood could start all the problems that we could see, including, for example, dysautonomia, which we could see in EDS and HSD. So the take-home message, yeah, the relationship between pain and culture, it is shaped by learning, observing, and that's why in a culture, as a mechanic said, children, they start learning and observing how the adults do and behave when they are in pain or distress. And they use the same vocabulary so as to communicate with the caregivers. So the children, they are taught, they learn from the adults and they communicate as though. So that's why it's very much important to understand how we should communicate and how we should think that not all the persons should think like me, but maybe I should start thinking that I have to understand the patient who I was dealing with, as Sir William Osler said. And the last one which I talk about is transcultural medicine. Nowadays, we think more and more that medicine should be transcultural, where we maybe combine the Eastern medicine and the Western medicine, not the healers and so on, but we combine both of them so as to give the patients the best remedies that could be best in their ways. Thank you very much.